Okay, so welcome everyone to today's Mental Health Experts one-on-one session. My name's Nicole and I'm your interviewer for today. I'm a researcher at Imperial College London and I investigate mental health, cognitive development and brain function in young people. We're very excited to be sitting down today with Dr. Kristina Sandström, who is our first guest. Dr. Sandström is a Chartered Counselling Psychologist with over 17 years of experience practicing within 3 nationally recognised services. She has expert knowledge and specialises in post-traumatic stress disorder, complex trauma, and attachment and development disorders and dissociations. She has a particular interest in understanding trauma through early attachment and focuses her treatment on finding healthy coping mechanisms and resources. She believes that therapy should be tailored to the individual and that it is about finding who you were meant to be before the trauma occurred rather than finding a new person who you are now. And she works as part of the EMDR Focus team, facilitating training for other professionals. So welcome, Kristina. Thank you for joining us today.
Thank you for the introduction.
So I just wondered if maybe we could start off with you giving an overview as to how you became a chartered psychologist and what kind of led you down that career path.
I think I always wanted to be working with people in psychology, and when I was younger I wasn't ready to take that big leap. So it was only when my life changed I took that step. And it's a long road, but I'm really glad I took it. So I did my degree with Open University when I was living in the Middle East. It was the only thing that was available. And then I carried on doing my postgraduate in London.
How did you find training in London?
Oh, it was really, really exciting. It was a little bit overwhelming at first, but I mean, London is fantastic because it's just so much available and courses, and it's a fantastic place to train in. And I was very lucky to be able to be there and do my training in London for sure.
And how comes you came to specialise in trauma and attachment disorders? What drew you to that?
Yeah, the short answer is that it was only when I started to practice doing my clinical practice training that I realized that I was drawn to trauma. And then it dawned on me that actually we have had quite a bit of trauma in my family, because my mother was very ill growing up. But I guess for me, it seemed normal because that's all I knew. But when I listened to clients and to our training sessions, I realized, oh, yeah, that's something that I actually experience. And this is something that I feel. So that drew me into that area. It's a way of understanding myself and also sensing that, because I really understood trauma and attachments that we probably come to from the inside out, so to say, I felt that this was an area I wanted to go into. That was really close to my heart, yeah.
And how would you describe trauma, or maybe more specifically, how would you explain post-traumatic stress disorder to people? What can they look out for if they feel like maybe they're experiencing a difficult time?
Yeah, this is a really interesting question. It's something that's so prevalent. I mean, if we're starting with post-traumatic stress, PTSD, to get a diagnosis of PTSD, you would have to have 7 different criteria. While trauma is something that's much, much wider, and might be important to know that trauma can really express itself in so many different ways. So the diagnostic criteria of PTSD is, that you have had to experience something traumatic directly or indirectly. You would have symptoms such as nightmares, flashbacks. You would have physical symptoms, hyperarousal, so heart rate that's increasing, or you're very shut down, or you will be irritated, angry, reactive, or what we call dissociated. So dissociated is, for those who doesn't know, is when we're sort of present, but we're actually not present. So it's like when the mind and body separates in a way. So that's something that often happens to us when we've been through something really traumatic. We can't actually physically leave, but our mind can leave. So it's a very clever survivor strategy. So it's 7 different criteria, but trauma, I would say, is much, much wider. And that's probably where my interest really came into this area, because people are struggling so much, but they might not fit into that, those 7 criteria to be classed as PTSD. So trauma can really look in so many different ways. You can have, the kind of common things: depression, anxiety, suicidality, phobic, social anxiety, anger outbursts, difficulties maintaining relationship, volatility, phobic, social anxiety, withdrawal, isolation. So it can express itself in so many different ways, and also somatically. So you can have illnesses that's just unexplained. There will typically be someone that has stomachache, headaches, migraines. There is no organic cause. They go to doctors and they get a clean bill of health, and there's nothing there specifically that can be pinpointed, but it's actually somatically, because the body holds on to the trauma, so it can express itself. And sometimes what we can't express in words, the body expresses in pain.
And how prevalent do you think trauma is amongst the general population? Because obviously we've all been through different experiences throughout life, and I think it's safe to say that it's more common than not that you would have experienced something difficult at some stage in your life. How do you know when it crosses the boundary from, just a difficult experience to something that actually becomes traumatic for someone? And how common do you think that actually is?
Well, I think to start with, how common it is, I think it's extremely common. I think it's just expresses itself in so many different ways. So where I'm coming from is that all what we call disorders are trauma-based, trauma-related in some way, shape, or form, whether it's bipolar or ADHD, often, or anything that we might commonly put into different categories. They're actually trauma-related because they come from, we haven't really got into attachment yet, but those very, very important early connections that we have with our caregiver. So I would say it's incredibly prevalent, as some people manages to kind of stumble through life quite well. I also think, just to hop back a little bit to your question, I also think just being on this earth as a human being is really traumatic. It's difficult. It's really difficult. It is more difficult now in so many ways. I don't want to go too far down that road, but before, 200 years ago, we were living in communities, for better or worse, but we were living closely with our families, and there's always someone there to mop up if our mothers were unwell or struggling in any way, with a grandparent or a neighbor. But now we live so isolated, and people are very, very isolated, and I think that is difficult to cope with isolation. So I think it's very, very prevalent. And how do we know when it crosses into something else? I think it is just when we find it difficult to manage our lives. When we can't do the things we want to do. then it's
There's something wrong.
Something else. Yeah, absolutely. And that's different for everyone, because some of us manages difficult emotions and struggles and sort of see it as part of life, and for the rest of us we can't. So it's very, very different.
Yeah, I really like how you tailor the support to the individual. I think that a lot of the time provisions are designed, kind of for a one fits all category. And I think it really is so unique to the individual. Just touching on that, so you mentioned attachment styles. So can you explain a little bit to us about your work that you do in relation to attachment styles and how they affect us?
Yeah, so maybe a little bit about attachment. So attachment is really, if we think about attachment, it's something that happens often with our main caregivers, and often that is our mother, because we are born to our mother, like it or not, but we are. So attachment is that kind of mirroring that happens between mother and child, because the child comes in, or the baby comes into the world really like a blank sheet. We come in just ready to adapt to our environment. So the mother is that, I'm saying the mother, of course, it can be the father or whoever is there to mind the child, but it really mirrors the child and regulates the child's emotions. So, for example, if you've seen, probably everyone's seen a infant that screams and gets really, really agitated. They're hungry, they're scared, they need their nappy change. Then the mother is there to kind of soothe them. And then the emotions sort of goes back into baseline, to what we call normal, and they're calm again. And that is, no mother can do that all the time. But when it happens over and over again, let's say that the mother is preoccupied, she's depressed, she's anxious, she has difficulty in her relationship, she had a difficult attachment to her mother, she might find it very hard to hold and regulate her infant's emotions. And so over time, that becomes the infant then feels, implicitly, because this is before thoughts comes into the picture, that comes much later on 2.5 and 3, but they feel unsafe. Right? They feel unsafe, and they're also starting to withdraw. Baby that doesn't get picked up when it screams, eventually they will give up and shut down. They will go into what we talked about, dissociation. They would just not give any sound, because everything is adapted to safety. It's all about keeping safe. So that's where early attachment comes from, very simplistically. Of course, it's more complicated than that. And that is what helps us regulate our emotions. So for those lucky people that had really stable, secure attachment, which I might say is not that many, they can get distressed about situations, but they very quickly return to what we call the window of tolerance, where they can think and feel. And the rest of us kind of tend to go either really high, anxious, or we just cut off. We go down into what we call hyperarousal. So that would be a sign of a nervous system that is not well regulated.
And when it comes to treating trauma and helping your patients through those experiences, would you say that a lot of the time either you connect the work or the work is connected to attachment styles when it comes to their trauma?
Yes, I would say almost all the time it is connection, because in my experience, and there are absolute exceptions, you can't say that anything is 100%, but people that have experienced really, really severe trauma, if they have had a secure or secure-ish attachment, the trauma tends to resolve quite quickly. I've seen this in the refugee population with some really horrendous trauma, and they has actually resolved. However, if there is someone that comes with a more insecure attachment, we tend to put attachment into kind of 4 different categories. Where the most kind of severe will be what we call disorganized attachment, where we find it very difficult to regulate. That's when the trauma is much more difficult to heal. Let's say, for example, a person has been through a car accident or a rape, robbery or something like that, and they come in and they have a disorganized attachment or some kind of less than secure attachment, then it is a more lengthy therapy work for sure than someone who's had a very secure attachment, in my experience.
Yeah, of course. Okay, could you maybe tell us a little bit about the different therapies that you use, if there's one in particular, and maybe if you could talk to us a little bit about EMDR?
Okay, yeah, so I became really interested in this, that working with trauma is working with trauma is really about the things that we don't know, working with the things that are often unconscious to us, and to go to the core, really the core reason for why we're feeling the way we do. So I quite quickly became interested in working more with what we call bottom-up therapies. So that means that, so for example, most of us know about CBT, which is fantastic if we want to, resolve some maybe easier difficulties we're having. So that's what we call a top-down therapy. We go in with our thoughts, emotions, and body sensations, simplistically. With bottom-up therapies, we start the other way around. We kind of start with the body access point, and then we go up to emotions, and then we kind of link that up to our thoughts more explicitly. So that's what I became interested in. So the therapies I are trained in was something called sensory motor psychotherapy. So that's a type of somatic therapy that uses, as I mentioned, the body as a entry point. So that would be, if you come to me and say that you feel angry, for example, I would say, well, where do you feel that in the body? Right? Instead of trying to work out why you feel angry, I would say, what do you feel that in the body? And then we'll kind of access the emotion through the body, because the body is holds so much information for us. So that's sensory motor psychotherapy or somatic therapy. I do also something called lifespan integration, which is really fantastic for people that might not be ready to do EMDR, because EMDR can be powerful, and I will get to that. So lifespan integration is a way, probably what the name is telling you, to kind of go into our lifespan and our timeline, and it's good for using, especially with someone who has severe dissociations, someone that finds it difficult to be present in the here and now. And it's quite a mild therapy, but effective. I also use something called internal family systems, which looking at the part of us, and the idea is that we all have different parts of us. You might be saying, well, a part of me really wants to go running today, but another part of me wants to lie on the sofa. So we all have different parts of us. And the idea with that is really not pathologizing what we're feeling, but understanding that this different part of us, parts that we really don't like often, that they have very often a protective function in our system. They are there for a reason. So I think that is a good way of understanding someone's internal landscape. And that's what brings me on to EMDR, because I recently started using that, or more recently started using that as a conjunction to EMDR. So EMDR traditionally was used for what I described as PTSD, trauma related, for the car accidents, for the military trauma, for the war trauma, and so on.
Yeah.
And there was the eye movement. A lot of people know that, following the eyes from left to right. Yeah. Now we use different methods, but it's both about kind of stimulating both sides of the brain, left and right side of the brain, and you're in that area, so you all know what I'm talking about. So, just a little bit about that, because I started at that then. So the left side of the brain holds through logical thinking, the things that we know, things that is available to us, analytical thinking, our thoughts. And the right side holds more our emotions, our feelings, and the things that are connected to our body that we're talking about. Of course, it doesn't exactly fall into that, making it very simplistic, but basically left and right brain. And the thing is with trauma, and I'm talking about trauma in a very wide range here, not just PTSD and anything trauma. There might things that we know. We know that the robbery we've been a part of, or the rape that we've been through, is in the past. We know that it happened 10 years ago, 20 years ago. We know it's not happening now. But the problem is that our body doesn't know it's over. It doesn't know that we are safe. So it keeps going around and round, the trauma that happens. It goes around and round like a tape inside us, the things that happen to us. So trauma in its essence is a time problem. It doesn't know that time has passed. So logically we know, but somatically body still holding on to what happened to us. And that is also true for what happened to us. We talk about attachment, early childhood, the things our parents say to us, the things that we were through, the feelings that we have, that we were not safe, or we were not wanted, or anything that happened to us, that stays inside us implicitly. It's inside of. We might not explicitly think about it, but that a lot of people doesn't feel good about themselves, have low self-esteem. They don't really know who they are. So that also comes from early attachments. And logically they know that, I'm as good as my friend or the next person, but they don't feel it inside. They feel that there's something wrong with them. So that's what we're talking about, the kind of difference between what we logically know and what we somatically, body sense, hold on to. So that is where we can go in with EMDR and trace back in time. We can sort of go back in time. We can do what we call an emotional time bridge back into the past to see, where did this start? Where did this feeling of not being good enough? Where did this feeling of anxiety, depression, suicidality, phobia, social anxiety, where did that start? And then we can find that event, and events is often several ones, and then we process that with EMDR. And when I'm saying processing, again, going back to left and right brain, so we have what we kind of logically know, and then we have the kind of implicit feelings in our body. And when the left and the right brain is starting to talk to each other, then that's when the trauma is starting to unfold and process, and our nervous system becomes calmer, really, and more regulated. So that's what we're after. We're after being more integrated, because trauma fragment us. We become fragmented into the path I was talking about. So that's really the aim.
Yeah. And in terms of, so obviously there's a lot of stigma around mental health. People don't like to feel as if they have something wrong with them, quote unquote. How big of a role do you think stigma plays in prolonging trauma, in impacting people's ability to recover per se? Do you think the stigma that there is around mental health, do you think that it impacts recovery in a lot of people? Or
Yeah, I think it does. And I think this is where I can understand that a diagnosis is very helpful, but it's also stigmatizing. I would really like to talk about mental health or the way we are in the world as on a continuum. And I think if we look at all the diagnoses, I think we all have been near some of them at some point in our life, or will be. Things will happen, life will happen, and we'll feel anxious, depressed, bipolar, whatever it is. So I think the diagnosis is often the things that's stigmatizing, and more saying that,
Yeah, it's interesting. So I practiced as a counselor for a while, and I found that for some people it was kind of freeing. They just wanted the diagnosis to prove, that there is something there. I'm not crazy. Whereas for other people, the thought of, having a label like that was something that almost made their symptoms worse and how they were feeling worse. How do you think? How do you think we can combat that? What provisions should we be putting in place to improve people's understanding of mental health, but also their relationships with mental health?
Yeah, I think you have a really, really good point there. And I think for a lot of people, it's a relief to get an ADHD diagnosis, for example, or so on. And, that's great. And then they get access to help as well. So that's the benefit of it. I think, again, normalizing that, yes, we can absolutely neatly put how you're experiencing the world and how you are in the world in a category. We can do that. And also, it's a normal reaction to an abnormal situation that people have been through, whatever it was, or just being on this planet. It's a reaction to being a human. So I would say that, again, and I think I sort of lost a little bit of your question, but stop me if I'm off topic here. But I think a little bit for us health professionals that it's important not to put ourselves, well, I'm the healthy one and you are the sick one and I'm here to treat you. I think that's really, really important too, to help sort of combat the stigmatization. And I think I really would like to see an increase in local help for people, not just from a psychologist, a psychiatrist, or psychotherapist, but groups from people that have been through different experiencing. You don't have to be trained for 10 years for that, just to have kind of first aid. We did set up something like that when I worked abroad with the Yazidi population. We set up a first aid trauma. And the CDs that were interested in that, we trained them, and then they went out into the camps and help others. And I just loved that. They didn't know exactly how to process trauma, but they went out and then normalized. They gave some stabilizing techniques, breathing, meditation, grounding. And then something like that, I think, not just into war-torn areas, but also,
in general.
locally, for us in the Western world too, that we can have more and more of that. I think
Definitely.
that will be.
I think for me at least, I think education, kind of that sharing of knowledge, is the way that you can improve people's understanding and their own relationship with their mental health, for sure. So lastly, last but not least, do you have any kind of words of wisdom that you could give people that either they're struggling or, you know, for in case they get to a time in their life where maybe things get a bit difficult? What would be your words of wisdom?
Yeah, I think that the hardest thing when we're struggling is that we withdraw from others. We tend to feel that there is something wrong with us. And this is the time when we really need connection. We really need other people, but we just don't feel like being in contact with other people. So I think first of all, whatever we are feeling is okay. And it's normal. It's normal. It's just a response to whatever is going on around us or what have been going on around us. And just something to add in there, because I talked about trauma as a time problem, and that things can be triggered in us. Something that happened to us 20 years ago can suddenly be triggered. And I think that's really important for people to know that our experience can lie kind of dormant in our nervous system, like in a little box. And then something happens that can be really super benign, and then it just opens up. So I think that's important to know that it is there is a reason for why we feel in the way we do, and that it is absolutely normal, and that there is help. There is help, and reach out. And I think this thing about if I am feeling it, I can be absolutely sure someone else is feeling the same.
Definitely.
Maybe for different reasons, but you know, I'm not alone in my experience. Other people are feeling that.
Yeah, definitely. I feel like we're at a time when we're more connected than ever, but I mean, it's a cliche, but we're also very disconnected from the people around us. And our communities, as you said, you know, just having maybe something in your local area can drastically change how you relate to your immediate surroundings, you know.
Absolutely.
Well, thank you so much for joining us today. It's been really interesting listening to what it is that you know, have dedicated all these years to. And yeah, thank you so much for being willing to join us. It's been lovely speaking with you.
Thank you so much. Thank you. Good to speak to you. Bye.